Welcome to the Global Hemophilia Report, a podcast where science meets storytelling to drive change. Produced by Bloodstream Media and Believe Limited, made possible thanks to our featured advertiser, Sanofi, and supported through our senior scientific advisor, Dr. Donna DiMichele. I'm your host, Patrick James Lynch, and today's topic, health literacy. What is it? How does it relate to health equity? And given the current political and cultural environment in the United States and around other parts of the world, how do we continue to serve members of the community who are most in need? It's a big topic with lots and lots to discuss, so we'll dive in right after this.
Sanofi seeks to break barriers for people with hemophilia through groundbreaking science so they can live beyond the limitations of their condition. Learn more about Sanofi's commitment at redefininghemophilia.com.
A missed dose, a misunderstood warning. Treatment denied because a patient couldn't navigate the fine print.
Do I understand what my doctor is telling me? Can I read more about what this condition or disease is? If I'm a person who goes into an office and I'm newly diagnosed, what am I understanding?
These are not oversights. These are consequences of a system where understanding your own health is not guaranteed. For millions of people with hemophilia and other bleeding disorders, making sense of medical information, treatment plans, and healthcare systems isn't just challenging. It can be the difference between stability and crisis, between life and loss. Health literacy isn't just about reading comprehension. It's about power. The power to understand, to choose, and to take control over one's health. And that power isn't distributed equitably. Health literacy is the foundation of health equity. It determines who can advocate for themselves, who gets timely care, and who is left behind.
When you don't have, health equity, when you don't have trust with your provider, you may decide not to take your medication. We see that when there are true shared decision-making conversations, people are more engaged. They ask more questions when they feel safe. They're more adherent to treatment, and they have better health outcomes.
That's why we planned this episode, to make it clear that health literacy and health equity are inseparable. But what we did not anticipate, what none of us could have foreseen, was just how quickly the very idea of equity itself would come under attack. Since the new administration took office here in the United States of America, we have seen intentional government-led rollbacks of diversity, equity, and inclusion initiatives. The very policies designed to close health disparities are being dismantled. Federal support for DEI in healthcare is vanishing. Research funding is being gutted. Even the word, equity, is being reframed as controversial. This is not an accident. This is a strategy. And it has real consequences.
So much is focused on race as the part of DEI or the part of equity. But if we're erasing DEI and we're erasing equity, then that erases all the social determinants. That erases everything that we're trying to work towards breaking those barriers for communities.
It's not just a policy shift either. It's uncharted territory. We have seen progress stalled before, but never a federal strategy aimed at erasing equity itself. The full impact of that? We do not yet know. And that is exactly why this conversation is more urgent than ever. Because history tells us one thing. When health equity, whatever we may call it, disappears from the conversation, vulnerable people pay the price. Gaps in healthcare grow wider. Patients who are already on the margins fall even further behind. And the burden of navigating an already complicated system becomes unbearable for those with the least support. So where do we go from here? That's exactly what we are exploring on this episode. We'll look at the growing barriers to health literacy, the real-world impact of rolling back equity initiatives, and the innovative solutions that providers, advocates, and researchers are fighting for. Because understanding your health shouldn't be a privilege. It should be a right.
I am Dr. Norris, the Vice President of Health Equity, Diversity, and Inclusion at the National Bleeding Disorders Foundation.
I'm Brendan Hayes, and I'm the Senior Director of Education for Innovative Therapies at the National Bleeding Disorders Foundation.
We'll be joined by other guests later in the episode. I appreciate, again, everybody joining for what is an urgent, timely discussion. So let's get into it with a little wide lens sort of table setting for people. So how do we think about health literacy and health equity, specifically within the bleeding disorders community? How are we defining these words, and what do we currently understand about the link between health literacy and health equity or access? Dr. Norris, maybe you can start on that.
So when we think about the overarching example of health equity, and we're saying that we're meeting communities right where they are, then that means that we are surveying each and every aspect of what that particular community needs at every level. And so when we think about it in that aspect, and we talk about health literacy, and we look at the literacy statistics in the US, right? 79% of adults, are illiterate or read at about a 5th grade level or lower across the US. That's astounding. And so when we have diseases that are as complex as rare diseases are, in regards to the language, in regards to care, in regards to shared decision-making between a provider and a patient, all of those things, literacy comes into play. How do I understand how to give myself factor or how much factor? Because your literacy then plays into whether or not you understand the instructions that are given to you for how to take any type of treatment or medicine and how often to take. And so these are things that could lead to major mistakes, right? Major complications and other issues. And more than likely, if you are in a certain health literacy realm, then those around you in your support system typically come from that same literacy background. And so there's not an advocate that's there that truly understands or can support or help you.
I think one of the things that I'll start off with, which I think a lot of people in our community, it will resonate with them. I remember when I have 2 adult sons with severe hemophilia. I remember when my oldest son was born, and I think he was maybe 2 or 3 days old. We had our first appointment at the Hemophilia Treatment Center. And I remember the physician who I'd never met before, Dr. George Buchanan. He held my hands and he said, "Brendan, you're going to have to know more than I do about hemophilia. So get ready for the adventure of a lifetime." And I'm thinking to myself, what in the world? I have to know more than you? Well, it definitely became evident as we progressed. And, my husband and I, we did all the things, we did all the research. And I think at that point in time, it was mid-90s, we were really seeing what it meant to be part, we were understanding what it meant to be part of this community.
Then you become reliant upon family members, friends, or sometimes within your HTC, there are social workers who are there to help you, but we have to consider how much time they have to take with each particular individual. So there are ramifications that just kind of ripple across, having low literacy, which leads to low health literacy, which leads to low understanding of even how your insurance works or how any type of patient assistant program works for you, how long that's in place before, the actual cost kicks in. So it just reverberates throughout the care continuum.
I think one of the things that's really interesting too is that, historically speaking, most people had, really 2 choices. They had to think about, do I want a recombinant product or a plasma-derived product? Then you fast forward again to about that 2015, 2016, we started hearing about bispecific antibody therapy. And that was life-changing, especially for people who had hemophilia A with inhibitors. I think it was a very underserved part of our community at that point in time. This was life-changing. life-saving for them. And then fast forward to today. Think about the innovation that we've had in the last 10 years. It is mind-boggling. And again, if you have had decades to learn about factor replacement therapy, and now all of a sudden I'm getting, all this new stuff. I'm getting ultra half-life factor products, extended half-life. I'm getting rebalancing agents and gene therapy. And I've got to figure out how all this stuff works.
So what I'm hearing so far from Brendan and Keri are that, we have a fundamental problem with health literacy. There's no reason to believe that it isn't impacting our hemophilia community and isn't impacting health equity and access to care and shared decision-making within our community. And yet at the same time, I'm hearing from Brendan that bringing people up to speed and addressing the problem of health literacy is something that's having to happen very fast now, all at the same time. And that is potentially increasing the potential for health inequity and disparities.
So that's always the risk when equity is attacked, when DEI is attacked as something that's totally just focused on race. Again, this is completely separate. This is about the fact that your health literacy is paired with your socioeconomic status. But more than likely, those at lower ranks of the socioeconomic ladder tend to be those who are, the fifth grade reading level or the sixth grade reading level. And it's not just reading level, it's comprehension as well. So when we have these programs that look at health literacy or completely ignore health literacy, and we have this rapid pace because we're seeing Brendan give us this vast knowledge of just what's happened in the span of 10 years. And I'm watching my colleagues in the education department and the medical information programs department, at the speed of light, updating information, updating resources for community members, and at the same time have to be thoughtful and mindful of how this translates. Can everyone read it? Can everyone understand it? Are we moving as fast as the science is moving? And that takes a lot of running and talking and singing at the same time. People are scared. It will create larger disparities. It will create more poverty, unfortunately. And then it will then become this barrier between healthcare systems and patients again, because the mistrust is that you no longer are concerned about me reaching optimal health. You just want to treat me and send me away. And it doesn't matter if I understand. You're just giving me something and telling me, go away, figure it out.
We'll be right back.
Health equity starts with understanding. Meet Shelley, a woman whose hemophilia diagnosis challenged stereotypes and inspired her to drive change. After years of unanswered questions, Shelley's story highlights the power of health literacy to close care gaps and uplift underserved communities. Scan the QR code or click the link in the show notes to watch her inspiring journey and learn how health literacy transforms lives.
It sounds complicated under the best of circumstances to ensure that the way in which we're educating and reaching people is akin to the pace at which science is developing. That's as an advocate, a scary proposition to begin with, let alone when facing such tremendous headwinds. Historically, what data or examples can we point to as shining stars of why this kind of sensitivity and approach and nuanced, literate approach has positive real-world outcomes?
My name is Magdalena Lewandowska. I'm an adult hematologist at the Indiana Hemophilia and Thrombosis Center, now known as Innovative Hematology. At Innovative Hematology, our first clinic serving women, girls, and people with potential to menstruate was really focusing on the adolescent. And we recognized pretty quickly that there are reproductive health concerns within the adult population that need to be addressed specifically. And so I started the adult version of the clinic along with a gynecologist, Dr. Hilary Gaudreau. There is a lack of understanding with regard to what is considered normal as far as bleeding symptoms related to reproductive health. And we've had women who had very significantly heavy menstrual bleeding or abnormal deliveries where lochia lasted for months after delivery, or they required blood transfusion after delivery. But because the family history was similar, this also happened to my sister, my mom, my grandma. This unfortunately was perpetuated, that this myth that women, that this is a normal symptom of reproductive.
My name is Kerry Funkhouser. I am the executive director for the Foundation for Women and Girls with Blood Disorders. When we were at a recent meeting with women with hemophilia, just sharing with them how much blood loss is typical in a normal menstruation cycle, they were shocked that they didn't know that that was normal and what they were experiencing was abnormal. So we have a long way to go still in terms of just educating ourselves about our bodies.
So participating in grand rounds, in patient-focused educational sessions through our local chapter, through Hemophilia of Indiana, really increased engagement in our patient population. And so then we noticed that there was growing interest from our plain community, our Amish patients, who also suffered from heavy menstrual bleeding. And our outreach nurses and APPs started sharing the existence of the clinic. And what we found was there were women who were willing to pay a driver to bring them to our center, which in certain situations was several hours away, just to meet with our gynecologist and their hematologist to talk about potential options to manage bleeding or bleeding around childbirth. And so what we realized was there was significant need in the plain community with regard to reproductive health care for women with bleeding disorders specifically. And we were not addressing that to the best of our ability.
We've been trying to reach them because everybody's had them on their radar, but just, it's been rural. We have money for rural. The nuance that's there is just like all other populations. Each rural community needs different things and looks very differently. And so that's a nuance that's there.
And what we also realized is the power of that community and the importance of meeting with their leadership in order to ensure that we would do things in a way that is culturally sensitive and appropriate for that particular population. We started by doing a pizza party and spreading the message, actually with regard to what such a clinic would entail, where the patients were able to meet with their gynecologist and gain increased comfort. This was followed up by a health fair to increase awareness of the types of procedures and that may be performed, including what a pap smear was. And we brought a nurse along with us who helped guide patients to allow them to understand what that would entail and why it was important and what other health screening would be recommended. And I think really meeting the gynecologist ahead of time and having that conversation and really gaining that rapport and the trust was also integral to the success of our clinic. And then we traveled with our team from Innovative Hematology, including 2 hematologists, myself and Dr. Single, and the gynecologist, Dr. Gaudreau, as well as our fabulous nursing support and our clinic coordinator. And then we saw about 30 Amish patients with bleeding disorders over the course of 2 days. And what we were really surprised at and really just amazed at how open these patients were and how great the need was. Because for most of these women, they had not met with a gynecologist to address concerns up until that point. Because many of our patients are delivered at birthing centers by midwives, or even if they do have a delivery by an obstetrician, it really is a limited interaction where they're not addressing things like heavy menstrual bleeding, cramping, anatomic issues, concerns for PCOS or endometriosis. They were so open and engaged, and it really felt like a wonderful outcome for the project.
I think the story we just heard is an example of a team really meeting people where they are at and taking into consideration a number of sensitivities and potential barriers and proactively addressing those so that they could have trust, credibility, rapport, and actually make a difference.
So how within the pivot, and like I said, either one of you can answer this, do we still address and meet different populations where they are, especially populations right now that are under duress, like, marginalized and minoritized populations, like our non-traditional gender populations, like our populations that are culturally non-American and that don't speak English as their primary language? How does that pivot still encompass that wide range of the people that we advocate for?
Our rural populations need more attention, need to be at front and center. Our youth need to be front and center and engaged, because navigating moving from your parents' house, who were the primary, insurers, and also the primary person that your physicians were speaking with, and all of these things, that navigation going from young person to young adult is a huge step with a lot of responsibility. And so you can get lost in the sauce there, or you can completely, now that you've moved out of the house, just kind of drop out and be like, oh, whatever. And there's a need for support. There's a need for us to dig in there. My team at NBDF created 5 strategic priority populations that we need to focus on for the next 10 years. Both of these groups are in there, along with women and girls, PPM, along with, other minoritized and marginalized populations. But the rural population and those who live in what would be considered frontier areas of the United States, they need this advocacy. They need health equity. They are in dire need for some of the very basic things that most of us don't even think about, let alone, health literacy being one of those stumbling blocks that could potentially be in place for them.
I'm Paula James. I'm a hematologist and a professor at Queen's University in Kingston, Ontario, Canada. So the social media part is interesting. And it's been an interesting journey for me personally and professionally. I'm actually not a big social media user personally, but in terms of what we thought we were able to do with health equity and health literacy, we had ideas, for my whole career about wanting to increase the amount of information that was out there for the general public and to make sure that it was accurate. There's a lot of misinformation, especially around reproductive health, and lies that people are told. We also wanted to make sure we were providing tools, and I've been very focused on bleeding assessment tools in my career and bleeding scores, and having those be a way to screen an individual. Because the thing about women's health is that bleeding is physiologic. And so some bleeding is normal, but where does it become abnormal? And so that's where bleeding scores, I think, have been very helpful in providing a way to tell the difference between normal and abnormal. So once we had those tools developed and had converted what were expert administered bleeding assessment tools into things that people could administer themselves, a self-administered bleeding assessment tool, we wanted to make it widely and freely available. And young people told me I needed to get with it and use social media. And so we created a website called Let's Talk Period. And that's really the whole point of the website, is to provide accurate information about menstruation and about periods. And there really is a very clear focus on the site for women with bleeding disorders and the issues that they face. And the self-bat is freely available in English and French. And we're hoping to do some other linguistic and cultural translations. And the uptake has been quite remarkable, actually. There's really an appetite out there for people to be able to get accurate information and also assess themselves. And so this self-bat, you answer a series of questions about your bleeding and you get a score, and then you get an interpretation of that score. Is my bleeding within the range of what could be normal, or is it abnormal? And then what do I do about that? What would the next steps be? So that's been very successful in terms of getting information out there. And we've taken a look at locally what's happened to referrals coming into my practice and the increase of people coming with self-bat scores or people advocating for themselves to get referred, and then the outcomes that are happening for patients, that if they've come through the website in some form or another, they're more likely to have more severe bleeding, they're more likely to need intervention. So social media has been a great way of us getting that information out there.
Paula, we love your tool and we use it all the time. I love the self-bat. And I love the fact that, the fact that patients can self-administer in the comfort of their own home, where they're not intimidated or asked very specific questions. As we know, bedside manner is key, and not everyone has that particular skill. So I think for patients to be able to self-administer a bleeding assessment score with regard to something as private as a period has really revolutionized our ability to screen patients for bleeding disorders. So thank you for all the work that you do.
Kerry Funkhouser from the Foundation for Women and Girls with Blood Disorders kicks off our next segment right after this quick break.
Health equity starts with understanding. Sanofi's global survey of 2,700 participants across 11 countries uncovers critical care gaps for people with hemophilia. Only 30% of patients report adequate care, and just 21% discuss overall health with providers, highlighting inequities in comprehensive care. Furthermore, 59% of caregivers face significant strain, proving unmet needs go beyond patients. Addressing these disparities is essential for equity. Scan the QR code or click the link in the show notes to explore the findings and learn how Sanofi is building a more equitable future for the hemophilia community.
Health literacy is really a pillar for the partnership between providers and individuals with these disorders. And just as we are trying to equip these LEAs with tools to help them be better advocates and be more literate about their conditions, we're also doing the same for providers, because if we don't have providers who are knowledgeable and are able to support these individuals, then we're never going to bridge that gap. And our work is very unique to other organizations in that we feel that, increasing the literacy of providers is key to helping individuals be better advocates and navigate the system and get the care they need. Providers may not see some of these conditions very often, especially the rare, ultra rare disorders. They need to be able to recognize the early warning signs, just like an individual with a potential condition needs to. They need to advocate for proper diagnostic testing, especially in a community like where I live, where there are no specialists. How do I get this individual the testing they need to find out what is going on? They need to understand what treatment options are out there, what's new, what's available, where can I access these, how can I help these individuals? They need to help prepare these individuals for life stage risks, whether it's in puberty or during pregnancy, after pregnancy, perimenopause, and then help work with them make informed decisions on what are their life goals and help them navigate that. So providing providers with the tools and resources to help these individuals that they are working with and caring for is essential to health literacy and health advocacy. And it is everything that we do.
Keri, you had talked so much about empowering the patient with information in order to be able to seek healthcare. And I just wanted to add that, some of the bleeding disorders that we treat are in the prevalence range of 1 in a million to 1 in 2 million. And many of our healthcare professional, physicians, APPs, nurses have not heard of many of these disorders. So our patients not only have to advocate for themselves, they have to educate their doctors sometimes about aspects of their management. I have a 9-year-old daughter. So I have 3 girls. My oldest is 9 and recently had a school discussion, right, about puberty and reproductive health. And the information that is being passed along, nobody actually teaches these young girls what is a normal period unless, they get it at home or from other members, right? Like if they have any other family members or friends may be affected with a bleeding disorder and have a connection with an HTC. I think there's a lot of women that we're missing, a lot of young girls that we're missing.
What role does health literacy or poor health literacy play in that average 9-year-old girl not getting the information she needs? I appreciate this is a multifactorial problem, but just to hone in, like from a health literacy point of view, what's useful to think about?
I think even the simplest things, right? I mean, using anatomic body terms and taking away some of the shame that has classically been associated with menstruation and reproductive health, normalizing those conversations, right? I mean, why do we not have charts of this up in the nurse's office, right? Of like 721, right? Or some of the typical things that we know would be considered abnormal for menstrual periods, right? Why do we not have information with regard to a hematologist they can contact, right? If a woman is seeing, or if a girl is seeing a nurse frequently because of heavy menstrual bleeding. I mean, I think there's various areas of intervention, but a big part of it is the cultural shift, which I know is a big part of the conversation because reproductive health is becoming politicized at the moment. But really, I mean, the more we can have these open conversations, I think we have a much higher chance of reaching these girls. I just worry that if we talk about, heavy menstrual bleeding and how frequent it is in society, I do worry that we're missing a substantial amount of children that we really should be reaching at a much younger age. Somebody said something to me at the last NBDF, which I thought was powerful. And it was a young woman with hemophilia. And she said, 13-year-olds don't listen to 30-year-olds. They listen to other 13-year-olds. So thinking about including lived experience experts with various ages, right? Starting from like a younger age, because they're out there. And some of these young people have a lot of very, very interesting and powerful things to say.
Well, I just would like to emphasize that the ambassador program, because the whole purpose of the National Research Blueprint as it was conceived of was to actually use lived experience experts in this ambassador program to increase research literacy. And so one of the things that I think has been tied in by the latter part of this discussion is, building upon, you have to build health literacy to actually build upon it research literacy so that not only can people understand the standard of care as it applies to them, but they can understand and partner with, healthcare givers and researchers on advancing the standard of care and what that means to the entire community. So I think research literacy is also important.
I'm going to, sort of end with the importance of shared decision making. And I think that we in the bleeding disorders community have an opportunity to teach the rest of the world what good shared decision making looks like. I think foundationally, it depends on trust, building trust with the patient and their provider. I think that's so important. And with the bleeding disorders community, because, people have these disorders from cradle to grave, we have the opportunity to build some really strong relationships with providers. And, I see it time and time again. I see it when it works well, and I see it when it doesn't work well. And I think that is a piece that we can all focus on. And really move the needle on health equity, when you can sit down and have a great conversation with your provider and learn, that's life changing.
Thank you all. Well, there certainly is a case to be made that health literacy and health equity are very well intertwined. And I think it's been very clear that whether on an organizational basis, on a provider basis, whether reaching out to the community, whether doing it through social media and reaching a wide swath of affected individuals, that you're all, creating an environment that is truly trying to increase health literacy and health equity as a byproduct of health literacy. In other words, empowering the people who need it most to seek the care, diagnosis, treatment, management that they need. And so as you go out into your clinics, as you establish tools, as you establish efforts, think about outcomes and think about outcome variables and how you might mention them, because I think that bringing data in from your incredible efforts is what will be needed to amplify those efforts through funding. So, keep up your great work, and thank you so much for sharing the wonderful work that you're doing on behalf of the populations that you serve.
I would like to thank all of our excellent contributors for adding their insights and expertise to this conversation today. And I want to highlight 5 key takeaways before we wrap up. Number 1, health literacy is power. When patients don't understand their condition or treatment, they cannot advocate for themselves. They cannot participate in shared decision-making meaningfully. Knowledge isn't just helpful, it is life-saving. Number 2, medical advancements and scientific development are moving faster than patient education. New treatments like bispecific antibodies, gene therapies are game changers, but only if patients and providers can keep up with the information they need to use them effectively. Number 3, health literacy gaps create barriers to care. People in rural areas, non-English speakers here in the United States, and young adults transitioning into their own care face unique challenges, and if we don't address these gaps, health disparities grow. Number 4, equity is under attack. The rollback of diversity, equity, and inclusion policies is making it harder for vulnerable communities to get the care they need. When equity disappears, health outcomes suffer. And number 5, solutions exist, but they need support. Whether it's from specialized clinics for underserved populations or the use of digital tools that improve access to information, we know we have some things that work. Now, we need the funding, advocacy, and action to bring them all to life in as effective a way as possible. Thank you all for listening, and I appreciate it if you could check out this incredible library of episodes that the Global Hemophilia Report has to offer. You can do so by visiting globalhemophiliareport.com or search for the Global Hemophilia Report on Apple Podcasts, Spotify, or anywhere you listen to podcasts. This episode of the Global Hemophilia Report was made possible thanks to our featured advertiser, Sanofi. Special thanks to Dr. Donna DiMichele, our Senior Scientific Advisor, Keith Kornelick, our producer, and the entire Believe Limited and Bloodstream Media team. We'll be back next month with another critical conversation. My name is Patrick James Lynch, and until then.
Sanofi is committed to bringing new perspectives and bold innovations to the global hemophilia community. Learn more about how Sanofi is committed to breaking barriers and supporting the community at redefininghemophilia.com.